I am privileged to introduce the next two speakers this morning, who will talk to us about the clinical researcher and the clinical provider, an oxymoron question mark. The first speaker is Dr. Ruth Faden. Dr. Faden has an MPH from University of California, Berkeley, and a PhD on psychology from University of California at Berkeley. Dr. Faden has focused her work on ethics and health policy with a particular emphasis in vulnerable populations. She is a professor of law, ethics, and health at the Johns Hopkins University School of Hygiene and Public Health. Her contributions to the field are immense. However, perhaps her recent most important contribution is to be the director of the Bioethics Institute. The Bioethics Institute was created in 1995. Its goal is to bring the moral dimensions of health policy, medical care, and other social sciences to the forefront of scholarship, teaching, and practice. We are grateful that she is with us this morning. She will address the important issues of, quote, therapeutic research, end quote, and the ethics of clinical research. Dr. Faden, please.
Thank you. If it's all right with everyone, I'd like to give my comments from this position. Is that congenial? But you can't hear me is the problem. That part's not congenial, right? Does that work now? Are we picking up? All right. The question before us this morning, whether there are inherent moral conflicts between the ends of clinical medicine and the ends of clinical research, between the role of the medical practitioner and the role of the medical scientist, has been before the medical community from almost the very beginning of the introduction of the clinical trial and the other elements of scientific research at the bedside. In 1953, Otto Guttentag, then a physician at the University of California School of Medicine at San Francisco, published an article in Science constructed around a comparison between the traditional role of the physician as healer and the relatively new role then of physician as medical researcher. Guttentag referred to the former as physician friend and the latter as physician experimenter. He explicitly laid out the manner in which medical research could conflict with the traditional doctor-patient relationship. And here I'll quote, "Historically, one human being is in distress, in need, crying for help, and another fellow human being is concerned and wants to help, and the desire for it precipitates the relationship. Here, both the healthy and the sick persons are fellow companions, partners to conquer a common enemy who has overwhelmed one of them. Objective experimentation to confirm or disprove some doubtful or suggested biological generalization is foreign to this relationship, for it would involve taking advantage of the patient's cry for help and of his insecurity." Guttentag worried that a physician experimenter could not resist the temptation to take advantage of this cry for help. To prevent such experimental exploitation, Guttentag proposed the following. Research and care would not be pursued, again I'm quoting, by the same doctor for the same person, but would be kept distinct. The physician friend and the physician experimenter would be two different persons as far as a single patient is concerned. The responsibility for the patient would rest during the experimental period with the physician friend, unless the patient decided differently. Retaining his original physician as personal advisor, the patient would at least be under less conflict than he is at present when the question of experimentation arises. And recall that this is written in 1953. Although Guttentag's language is perhaps a little old-fashioned and flowery, Guttentag's framing of the problem is as accurate today, if not more so, than it was nearly 50 years ago. Guttentag's proposals for keeping the roles of healer and experimenter distinct by embodying them in different persons with respect to specific patients, fell, as we know, on deaf ears. Instead, we evolved a practice in clinical research in which, for many patients who are research subjects, there is a seamless web connecting their medical care and the research. The investigators conducting the research are also the physicians from whom these patient subjects are receiving their medical care. And from the perspective of the patient, it is the latter role, the healing role, that dominates. What I'd like to do this morning in my brief comments is twofold. First, I would like to make explicit what is perhaps obvious, that is the nature of the moral conflicts that Gutentag envisioned and that we live with today. Second, I would like to focus in particular on the kind of medical research in which these conflicts are the most acute, that is, research involving the seriously ill. Here I want especially to emphasize the complicating human dynamics of hope and the desire to nurture hope, particularly when the medical outlook for the patient is bleak. And let me also introduce a kind of background caveat. I'm not going to be speaking here specifically to the military context, and a sort of operative hypothesis I have, and I'd very much be interested in this in discussion, is that perhaps unlike other areas of research in the military, clinical research with the seriously ill, I submit, is in all moral respects not really distinguishable from clinical research with the seriously ill outside the military context. That is, the really key critical moral issues are essentially the same, defined primarily by the tensions I'm about to outline. But I'd be very interested to hear in this group whether there is a view that the military context, the addition of yet a third role for the physician as an officer in the military, introduces yet another complicating factor. I see a very clear distinction or defining difference for other kinds of research conducted in the military, but here I'm speaking specifically to clinical medical research with seriously ill, largely hospitalized patients. So let me begin. As intimate as these two practices have become, that is, clinical research and clinical practice, in their origins and their ethos, medical research and medical practice are profoundly different. They have different ends, and these ends highlight different moral values and define for their practitioners different roles. The end of medical practice is to advance the health and well-being of the patient. The physician-clinician's primary moral obligation to the ill patient is to the patient before her, and the physician's primary consideration in making recommendations about medical management is that patient's welfare. The end of medical research is the creation of generalizable medical knowledge. The investigator's primary moral obligation is to the science, and assuming that the research is otherwise ethical, the investigator's primary consideration in interacting with the subject is fidelity to the research protocol. When the medical research becomes clinical research, the subject is also a patient, the investigator is also the subject patient's physician, and the protocol is the only or the principal source of the patient's medical care. Which obligation becomes primary then? The obligation to the patient or to the science? Many would argue that the obligation to and interests of the patient are always primary, even in clinical research. But this is, I submit, naive. There are instances where it is in the patient's clinical best interest to be enrolled in clinical research. That is, there is a reasonable expectation that the patient will be better off medically on protocol than with standard care, and adherence to the protocol does not require the patient to experience any additional discomfort, inconvenience, or pain. Much of clinical research does not, however, fit this paradigm. Often the best that can be reasonably claimed is that the medical prospects for the patient are no worse on protocol than off it. And often as well, the protocol typically involves additional procedures and interventions that are burdensome and that are not necessary for the medical management of the patient. Sometimes even this cannot be claimed. In some clinical research, for example, some phase 1 clinical trials, there is no reasonable prospect that the patient will benefit medically from the research, and the research imposes on the patient a significant risk of discomfort, even a prediction of discomfort, or even of suffering. In clinical research of this type, it cannot plausibly be argued that the medical best interest of the patient is the primary moral consideration. Here, the physician is acting primarily as a scientist, not as a clinician. A central problem is that the patient often does not have that understanding. The patient is operating under a therapeutic misconception, the misconception that her therapy is the end of the enterprise, when in fact the end of the enterprise is the advancement of medical science. Nowhere is this misconception more apt to occur than among the seriously ill. Empirical research about the practice of clinical investigation, including research conducted by, this is such a long title, President Clinton's Advisory Committee on Human Radiation Experiments, which I had the privilege to chair, and which was conducted in part, by the way, I should mention, in military hospitals, suggests that patient subjects generally decide to participate in medical research because they believe that being in research is the best way to improve their medical condition. That is, they decide to participate because they see this as the best way to advancing whatever their medical problem is. Studies also suggest that subjects frequently have an inadequate, sometimes exaggerated understanding of the potential benefits of the research in which they are participating. In a review of the research documents of 125 medical studies active in the 1990s conducted by this advisory committee, some consent forms were found to clearly overpromise what the research could likely offer the ill patient, while simultaneously underplaying the negative effects of the research on the patient's quality of life. These were the kinds of disclosures that could easily be interpreted by a patient desperate for hope as offering much more than realistically could be expected. Not surprisingly, this problem was the most acute in certain phase 1 trials that offered only the remotest possibility of benefit to patient subjects. In oncology, for example, it is estimated that only about 5% of patient subjects enrolled in phase 1 chemotherapy studies, that in only about 5% does the tumor respond to the drug. And it is often unclear even then what the tumor response means from the patient's point of view. To say that patients never benefit is too stark. There are enough cases of patients being helped in phase 1 trials to make such an unqualified, absolute claim problematic. Beneficial effects of phase 1 trials have a very low probability, but they do occur. At the same time, however, any suggestion of the possibility of benefit has the potential to be magnified many times over by patients who otherwise have no good medical alternatives. Patients, as it were, at the end of the medical road. It is understandable that patients with poor prognoses may read hope into even the slimmest possibility of benefit. It also is understandable that physicians, uncomfortable with having little to offer their seriously ill patients, might at such times inadvertently impart more hope than the clinical facts, strictly speaking, warrant. Hope is a delicate and precious commodity for those with life-threatening illnesses. At the same time, there is a world of moral difference between a physician emphasizing, even inappropriately, slim chances out of a humane desire to bolster waning hope, and a physician emphasizing slim chances in order to meet a recruitment goal for a clinical trial. Feeding hope at the expense of candor is one thing. Exploiting the desperation of those whose lives hang in the balance is another. One of the most powerful themes to emerge in research about research, empirical research about the clinical enterprise, is the role of trust in patients' decisions to participate in research. Patients, especially seriously ill patients, trust their doctors because they need to trust their doctors. They need to believe that their doctors are acting only out of concern for their best interests, and that everything that is being done to them is being done for them, for their benefit. This is the psychology of illness, the psychology of dependence, and desperation. This psychology is also the root of the therapeutic misconception, and it is the root of the moral quandary facing physicians who would simultaneously be both healers and scientists. There are no moral bright lines to follow here. Indeed, this is morally perilous territory in which we must tread humbly and only with the most careful and continuing critical reflection. Thank you.
Thank you, Dr. Faden. I will now introduce the second speaker. Dr. Lasagna received a medical degree from the College of Physicians and Surgeons at Columbia. He serves now as the director and chairman of the board, Tufts Center for the Study of Drug Development. He's also the dean, Sackler School of Graduate Biomedical Sciences, and the dean for Scientific Affairs, Tufts University School of Medicine. Dr. Lasagna has worked and written extensively in the areas of clinical trial methodology, analgesics, hypnotics, medical ethics, and the placebo effect. He serves on a number of editorial boards and as a consultant to the NIH and FDA. He also serves in the GAO's Health Advisory Committee. He was chairman of the National Committee to review current procedures for approval of new drugs for cancer and AIDS. In 1990, Dr. Lasagna was appointed to the Blue Ribbon Panel, which examined the FDA. More recently, in 1995, Dr. Lasagna became a member of the Rogers Group. The Rogers Group is a committee of 4 highly esteemed and eminent scholars who are charged to prepare an agenda for legislative reform of the drug regulatory process. Therefore, he's uniquely qualified to speak in this topic, and we are very grateful that he is with us this morning at this symposium. Dr. Lasagna, please.
Thank you. Can you hear me? First, some additional descriptors and disclaimers so you'll know whether to add to or subtract from whatever I'm about to say. I'm a Euro-American of Northern Italian persuasion. It was described last year in a Washington periodical as the venerable director of the Center for the Study of Drug Development. I looked up venerable, and I won't bore you with what the dictionary says. There are some nice things about it, but it mostly turns out that if you're old, you can be venerable. I really like to think of myself as a clinical pharmacologist, although I actually am not 2 but 3 deans at Tufts, because being a dean carries more responsibility than fun with it, and being a clinical pharmacologist, I think, is the other way around. I also am very fond of the story of the Brown University alumni group that once wrote to a high official at Brown asking for a speaker for one of their meetings, and the letter ended with the request, please don't send us anyone lower than a dean, to which the official responded, have no fear, there is no one lower. I'm proud of the fact that there are 4 members of the board of Primer here. I know that some of you I've had a chance to interact with at Primer meetings, but Dr. Levine, Dr. Freeman, and Charlie McCarthy are all very important members of our organization. Well, what experience have I had with the military? Well, not a lot. The Navy sent me to medical school, and then I was supposed to go to what was then called the National Microbiological Institute to pay my time back through the Public Health Service, but I got seconded to a ridiculous cloak and dagger grant from the Army, which allowed me to go to the Mass General and work on psychotomimetic drugs, because my boss, Harry Beecher, had come back from Europe and told the Army that the Russians were building not 1 but 2 factories beyond the Urals to manufacture LSD, which they would then drop into the cocktails of important Americans at social functions and take over the world in that way. I didn't know what the contract was about, because I knew about what Beecher was doing with pain and subjective responses, but you had to be cleared for top secret for this crazy grant, which I was. But when the general from Edgewood Arsenal called me and asked me whether I was willing to go there, I said, well, what am I going to do? And he said, it's too secret, we can't tell you. Our reports used to be carried down to the Pentagon by an armed courier with the reports manacled to his wrist, and occasionally the report would get lost in the Pentagon. They'd ask for another copy. The nicest thing about those years at the Mass General was working with Harry Beecher, who, as you've heard previously at this meeting, and I'm sure knew anyway, in the 1960s, wrote this seminal article on informed consent. And when he sent me the draft of it to comment on, I said, Harry, you remember when I was with you from 52 to 54? We never got consent from anybody. And the only thing we ever got was with the healthy volunteers who were in our Army grant research. We got them to sign releases so that if anything bad happened to them, they would not sue the Army. That was the extent of our preoccupation with informed consent. And he said, well, I'm not saying I was without sin. I said, well, I don't see anything in this paper that acknowledges the bad things we used to do. I said, why don't you write to some of these people, because it hasn't been traditional to mention these matters in publications. Maybe some of them actually got consent and didn't mention it. And he said, no, if they got consent and didn't put it in the paper, it's as bad as if they hadn't gotten it at all, which reminded me that Harry never wanted the truth to interfere with a dramatic story. Finally, I did write a chapter on chemical warfare at one time, and that's it as far as my interaction with the military. There's unquestionably, as we've already heard from Ruth, a potential for conflict between the health professional's role as caregiver and his or her role as clinical investigator. But I would submit to you that the tension is more complex than might be suggested by the dramatic title of this part of the program. Thought it might be helpful at the start to enumerate some of the roles that can be played by physicians as research is planned and carried out. This is not new to you, just to remind you. Now, I'm trapped of necessity, like everybody else is, by my personal career experiences. So I'm going to discuss primarily the pharmacotherapeutic area, but I think the principles are generic and apply to other types of research as well. Although I must confess, having been for 10 years on an IRB, we so rarely get anything from the surgeons or the radiotherapists that I wonder, don't they do research? That diddling around that they do with better ways of doing this or that, or more radiation or less radiation or different portals. Surely there must be some research going on. Why don't we get stuff at our IRB? And I don't know the answer to that. A key dimension, I would submit, relates to the existing pharmacopoeia. That is, at any given moment in time, how good are the already available medicines? In the situation where an excellent medication exists with predictable benefit of a satisfactory degree to most patients and only trivial side effects, I would say that studying a proposed alternative in a trial that may expose a patient to either placebo or a new drug of unproven worth and safety poses serious ethical and medical issues, and the care provider would have a difficult time, in my view, justifying the recruitment of her or his patients into such a trial. On the other hand, in the case of a serious disease for which no drug is available that provides meaningful benefit or is untainted by frequent or serious toxicity, the conscientious physician might not need many reservations about if any, about the enrollment of a patient into a clinical trial, provided there is reason to believe from a theoretical standpoint and on the basis of preclinical data that the drug candidate offers promise of therapeutic progress and tolerable side effects. I know that may not turn out to be the case, but there's got to be the promise there. A similar situation exists when the pharmacopoeial cupboard is not completely bare, but the patient has failed to respond to standard therapy, a not uncommon scenario in many aspects of medicine, as you know. I might say ordinary medical care not infrequently involves trial and error stuff with medications. The rheumatoid arthritic may not respond to treatment A because the efficacy isn't good enough, or not respond to treatment B because there's intolerable toxicity, and finally gets to treatment F, and that seems about right for that patient. I don't consider that research, although the results may be indeed beneficial to the patient. There is the trial of the N of 1 trial approach, which is, on the other hand, research, although the results may not be generalizable to anybody except the one patient that is being studied. Now, much less straightforward is our usual scenario, where we do have marketed treatments, but their performance, albeit not negligible, leaves a lot to be desired. Here, the research subject may personally benefit from participation in a trial if she or he receives a new drug that turns out to represent a distinct improvement over the old, and sometimes they do. Complicating matters is the regulatory need, at least in the United States, for demonstrating superiority of a new drug to placebo as opposed to comparing it with a standard marketed drug. The FDA's position is that while unequivocal superiority over a standard drug may be persuasive, indeed, simple failure to distinguish between new drug and old drug may reflect not equal performance, but rather an experimental population that is incapable of distinguishing between good and bad. To avoid marketing a drug that is in fact inferior to the old but is labeled incorrectly, the requirement of a placebo arm may be justified by a sort of statistical morality. I hasten to add that in situations where dose-response relationships are demonstrable, such data would both serve the regulatory purpose and avoid ethical conflicts. An example of this kind of unpredictability would be severe melancholia, where it is not uncommon to do a trial comparing a standard antidepressant with a placebo and not have the two treatment arms distinguishable one from the other. The physician qua healthcare provider can play a useful role with regard to certain other research procedural needs. Since most phase 1 studies are performed in healthy volunteers, I like that rather than normal volunteers, because I once gave a talk called How Normal is the Normal Volunteer. Since most phase 1 studies are performed in healthy volunteers, a physician other than the research physician can evaluate without conflict of interest the available preclinical data to advise either IRBs or potential volunteers on the appropriateness and defensibility of the research protocol or the intelligibility of the proposed consent form. Now, there's a trouble there because the average physician doesn't read at a 4th grade level, reads better than that. Somebody there is kind of like this. And our IRB has nobody sitting around the table who reads at a 4th grade level or even an 8th grade level. They're all smart people, and that's a problem. But I must say, whenever I confront a dense and unreadable 15-page consent form, I yearn for an additional 1-page form that communicates clearly the general purpose and nature of the proposed research without the excess verbiage that represents a triumph of form over substance, and which only makes happy, I think, the lawyers who are warning you that if you don't have everything in there, you may suffer litigation. Now, some special problems, I would submit, exist with regard to cancer and AIDS patients. Cancer patients not curable by the surgeon's knife or by the radiotherapist's beams often need to be referred to cancer centers, since research there offers at least the hope of help, and as Ruth has said, don't knock hope when you've got a bad disease. Most cancers cry out for discoveries that will provide effective therapy. Some physicians, seemingly fearful of losing patients from their practices, are reluctant to refer patients to such centers. When cancer patients do volunteer for phase 1 studies or phase 2 or whatever, it is usually not for the benefit of other cancer patients or future cancer patients. It's for the possible identification of a new treatment that will help them. That's why they're volunteering. The best way, at least for the traditional cytotoxic drugs, to achieve that goal is not to increase the dose in different patients, but to push the dosage of a new drug in each patient to maximally tolerated doses and look for some evidence of decreased tumor burden. Exposing patients, as we often have done in the past, only to small doses almost guaranteed to be safe, but also almost guaranteed to be ineffective, does not begin to approach the patient's goals. Now, AIDS patients volunteering for phase 1 studies run the risk of developing resistance to a drug that might otherwise be beneficial to them via exposure to doses of the new drug that are not adequate to achieve benefit, but large enough to induce resistance. And such acquired resistance may rule out eventual clinical benefit to such AIDS subjects, AIDS patients, from the drug as the optimal dose of the drug is later identified. Now, there's another regulatory problem that has to do with the FDA's usual demand for 2 persuasive studies. By the way, Carl Peck, who used to be at the FDA, tells me that CBER, one branch of the FDA, only requires 1 study by and large, whereas CEDAR requires 2. If that's true, and Carl's probably right, I think the FDA ought at the very least to explain why one does it for one arm of the FDA and it doesn't for the other. Anyway, it's easy to understand why a cautious federal agency or even an academic scientist would want replicates, because the essence of science is replicability. But after 1 thoroughly convincing study has been completed, either in the US or abroad, and even when performed unethically somewhere, the ethics of carrying out the replicate, to say nothing of how to write the consent form for the second study, becomes dicey indeed. Now, other conflicts. There may be important goal differences between the researcher and the caregiver, as Ruth has already pointed out. A trial is, quote, successful for the investigator, for the sponsor, for the FDA, for editors, if the group on drug fares statistically and in a clinically meaningful sense better than the group on placebo. But the clinician, as Bradford Hill, grandfather of clinical trials in Britain in the 40s, pointed out 30 years ago, that the clinician doesn't want to know about Mr. or Ms. Average, because there is no such person. Wants to know about Mr. Jones or Mrs. Smith. So as Bradford Hill has pointed out, the group performance doesn't really tell the doctor, or indeed the patient, what he or she wants to know, which is, how do I know which drug is best for this person, this specific patient? Indeed, retrospective peeks at the data for clues as to factors predicting success or failure are often scornfully criticized as data dredging. Now, go back to that old Heberden oration of Bradford Hill. Let me quote what he said. If there is and he's quoting here, an unpredictable multitude of factors which can influence the outcome, end of quotation, then surely it is our job and duty to see whether in the analysis we can identify them and thus make them predictable. To seek through one's data for clues with an exacting conscience and with a cautious outlook is demanded of every investigator. The clue may well be no more than a clue. Certainly we may not wish to draw conclusions, but with a bit of luck we may have learned something that we can put to the test in future observations and perhaps in a further trial. So for the medical practitioner, the goal of therapy, I would submit, again, is to maximize benefit and minimize harm for the individual, not the group, regardless of the legitimate interests of the other dramatis personae. If you're in biology or the biological sciences for a short period of time, you quickly learn that all humans, like all animals, are not created equal. And yesterday we heard about the stigmatization of a patient if you can identify a factor that distinguishes them from another patient with regard to either benefit or harm. I would submit that that's nonsense, that if we can figure out that age or gender or left-handed Lithuanians respond better than other folks, that I would consider not a stigma, but a blessing that would allow one to make more effective use of one's therapeutic agents. Now we have a new complicating factor, and that's the growing demand for pharmacoeconomic data by foreign pricing authorities, HMOs, hospital formulary committees, and other reimbursement decision makers. Everything is outcomes research these days. I have a colleague who's an MIT economist who says that outcomes research is like teenage sex. Everybody talks about it. Few people are doing it, and nobody's doing it well. A new drug must increasingly, by the way, nobody's surveyed the teenagers to ask them how they feel about that. My MIT colleague is well beyond that age. A new drug must increasingly provide an advantage over available therapy to justify its being prescribed or paid for, or both. Now, what do we mean by better? Well, more effective, either for the entire group, the entire universe of potentially treatable patients with that disorder, or an identifiable subgroup, safer, ditto for everybody or for an identifiable subgroup, more convenient, or cheaper. Cheaper is good. That's very good. Such demands make sense from a societal standpoint, but in designing trials, some of those goals may pose ethical issues, such as the search for a new drug that may be less effective than the best available standard treatment, but lots cheaper to make, for example, and to sell. Well, finally, let me try to capture the essence of a fascinating article published 12 years ago by Sider and Clements and entitled "The New Medical Ethics, a Second Opinion." These authors contrasted the new medical ethics against the traditional medical ethics of the physician, whose major concerns have long been with what is chosen, not who is to choose, and with minimizing suffering and maximizing health, not autonomous will or informed consent. In many quarters today, reliance on the patient to choose his or her own good is considered more dependable than altruism, ignoring the ability of some patients to be self-destructive or to take needless risks. Bioethicists today are sometimes magnificently ivory towerish, not accountable to subjects for the consequences of their intervention, whereas physicians have long been so accountable. Now, have physicians been wrong to consider a good medical outcome as more important than the freedom to make the wrong choice? Is autonomy invariably more important than beneficence and maternalism? Is the political legal model the most appropriate basis for ordering the patient-doctor relationship? What of the situation where a pregnant woman demands the right to volunteer for a study where benefit is unlikely and fetal damage is a real possibility? Whose autonomy should prevail, the investigator who would refuse to enroll such a patient, or the patient? And if overruling the investigator's autonomy results in the entire study coming to a halt for men and for non-pregnant women, is society really better off? I might add that I have no qualms at all about exposing a pregnant woman to an investigational drug if there's reason to believe that that pregnant woman might indeed benefit from that exposure, and provided that the risks and benefits have been accurately and clearly laid out for such a patient. But I would consider such a woman part of a vulnerable population, or if you don't grant me that, grant me that the fetus, at least, is part of a vulnerable population. As indeed are lots of patients. The patient dying of cancer is a part of a vulnerable population. The child with cystic fibrosis is vulnerable. The patient with amyotrophic lateral sclerosis is part of a vulnerable population. The Bureau of Prisons of the Department of Justice has recently published in the Federal Register their final rule on research. This bureaucracy is clearly opposed to any and all pharmaceutical research in prisoners, despite the fact that class action suits have been filed by prisoners to allow them to volunteer to be research subjects. Now, my interviews of prisoner subjects and visits to prisons have been limited. Postdoc and I did one study in prisoners in a Baltimore prison, and I have visited a low-security prison to see what they were doing research-wise in Montana, and a very high-security prison in Michigan. By the way, in Montana, they gave me a little piece of paper making me an honorary prisoner. I have no doubt that at least in a high-security prison, the research ward is the safest place for an inmate. Prison doctors can certainly attest to this fact and to the abundant evidence that fractures, beatings, rape, and murder are risks where? In prison cells, in prison showers, in prison exercise yards, not prisoner research wards when they used to exist. Now, the Bureau of Prisons has in this instance voted clearly for paternalism, maternalism, and against autonomy. Are these individuals right or wrong? Are they benevolent dictators or meddlesome, ill-guided tyrants? Are they protecting prisoners, or in the words of one prisoner that I interviewed, depriving them of one more freedom than they've already lost? I raised this Federal Register ruling and the Sider-Clemens paper in part to be purposely provocative, because I like to do that, but in part also to discourage the belief that the answers to the questions we are discussing are simple, are universal, are unchanging. To treat them as such, I would submit, is to do a naive disservice to individuals and to our society. So instead, let's consider the fallibility, the possible fallibility of our views, the need for repeated empiric challenge to whatever views are paramount at the moment, and the ethical mandate, at least on occasion, for change. Thank you.
We have now the questions and answers period. We have 2 microphones, and also if the people that are helping us with the cards will please circulate among the audience to bring some of the questions to us.
This appears to be a good point to bring up the issue of why we don't routinely financially compensate patients for participation in research.
Well, at our major teaching hospital, we do. Not invariably. We do have concerns about the appropriateness of reimbursement. I'm never quite sure how we decide what's appropriate and what's excessive, but it's not unheard of for patients, at least at the New England Medical Center, to get modest reimbursement for participating in research, in addition to having their expenses paid for, insofar as their expenses are related solely to the research protocol. Ruth?
Actually, my sense of the issue of financial compensation is very much tied to perceptions of whether the research has the potential for medical benefit for the subject. Financial compensation, in my experience, is rarely offered where there's a construction in the mind of the physician investigators that there is a chance that the subject as patient may benefit, that this in fact is substituting for their medical care. Where you see financial compensation commonplace is in the case of the healthy volunteer or otherwise a patient who is participating in a study that is totally unconnected to their medical management, where the understanding is somehow they need an incentive or they're otherwise due some sort of compensation for their investment, or if you like, for their sacrifice. One of the issues that I've been struggling with for a long time is the extent to which that distinction holds up in many, many borderline cases, and whether if we had a rule of that sort, we might find ourselves challenging the context in which we feel payment is appropriate and those in which we don't.
Phase
I think that's a very troubling scenario that you lay out. I think it's a very troubling scenario that has just been proposed, and I have actually thought about this general problem in the context of what I like to think of as unwelcome offers, and whether you understand them to be coercive in the sense that they are unacceptable is really the key issue. The context is basically this. You have an opportunity that the patient sees as maximizing her interests, and her treating physician agrees that that's so, but there's a price to be paid, and the price is essentially the context of the unwelcome offer. You can have a chance, but at the following cost to you, and there's no alternative way to have access, presumably. You can't get that drug off protocol. Let's just stipulate that for a moment. One of the issues that emerges for me in that is how you construct at what point such an offer becomes, again, an unwanted, not only unwanted, but unwarranted exploitation of the desperate circumstances of the patient. I would agree with the characterization that Dr. Lasagna introduced, that you endorsed, that whatever we think of the term vulnerable, we have probably forgotten that among the most vulnerable, if not the most vulnerable, in the group of people who are potential research subjects are the seriously ill. This has become one of my central concerns as we construct a kind of new look at the ethics of research. And it's precisely at the seriously ill that these kinds of unwanted offers are the most problematic.
I just make two comments with regard to the point that's being made. One is that although I have no doubts in my mind that the advent of IRBs and informed consent is a big step in the right direction when I contrast to the sorts of shameless things we did in the 1950s that I referred to earlier. But that doesn't mean that we should be complacent about IRBs or think that an informed consent form is the same as informed consent. We have to keep asking ourselves, what could we be doing better? And I submit there are plenty of things we could do better. The other point I would make is that I think this came up yesterday at one point, this multi-clinic problem where you're given a protocol and you say, well, the National Heart Institute or the National Cancer Institute has gotten together and they've put this protocol together, and it's already been approved in 6 other places, but why are you giving us a hard time? And my answer to that is that it's not our job to comport ourselves in agreement with what other IRBs have done. We've got to ask ourselves whether taking a patient off antihypertensive drug for that period of time is acceptable to us, or if having the blood pressure rise to this point but not that is okay. You know, these are decisions that I think are less related to the nature of the patient population than perhaps to the opinions of the experts you have at your own institution. But I don't think it's a way out to say, well, you just got to sign a blank check because a bunch of other IRBs have approved it.
I think we're losing perspective when we try to separate medical research from clinical practice. I think that the ethical practice of medicine is the application of science to the individual patient. And every medical practitioner should be a medical scientist, constantly evaluating whether what he's doing is working or not. And then if you think about everything we do in taking care of a patient, whether it's history or physical exam or laboratory tests or therapy or counseling, these all involve probabilities which we often have very little knowledge of. Sometimes we know those well, usually we don't. And if we are going to take ethical care of patients, then we have to be setting up our practice and our information gathering in such a way that we can better understand what those probabilities are. And when we call that medical research and put it under such strict rules that it makes it impossible to conduct in a practice setting, then we're doing more harm than good. If I think about a patient, for example, who I have a treatment available that I know has a 40% efficacy, but there's also another treatment which we think might have a 60% efficacy, I think it's my obligation to give the patient that choice. Do you want the sure 40%, or do you want the potential 60%? If so, we enroll you in this clinical trial, and we follow the procedures to give us the best information so that in the future we'll know for sure whether it really is 60%. And that really is the crux of the issue. in doing this. And when we make it too difficult to incorporate that into our clinical care of patients, we're doing them more harm than good, and we're really not practicing in an ethical profession.
Well, there's certainly similarities between clinical practice and research, but there's certainly dissimilarities too. I don't think I've got anything to add with what I said before.
Yeah, I think perhaps it's a little facile to completely analogize the kind of individualized trial and error management of the sort that Dr. Lasagna described and what we understand to be clinical research. But that said, I thought you were going to go to a different point, which I think is in fact quite related to the issue you were describing, and that is you could make a good case that it's almost impossible in some circumstances to figure out the difference, and that it's not in the actual practical setting, and that it's not only the patients who are confused about what's going on in the enterprise, but the physicians and nurses as well. I mean, there are some contexts in which there is so much interdigitation, so much interweaving in a clinical environment between the research. Cancer centers are very good examples of this, but also in AIDS clinics, where you really, it's all of a piece. And that just makes things all the more confusing because, in effect, everybody's on protocol, sometimes on 3 or 4 protocols, and everybody is both caring for the patients and trying to be doing right by the research and operating almost always on a case-by-case basis. In this instance, am I going to pull this patient out or suggest that we pull this patient out or leave the patient in, and having to make all of those decisions, trying at once to be a good doctor and at the same time to advance in one's career as a medical scientist. This is where the sort of rubber hits the road in that kind of an environment, and not so much the sort of neat, tidy environment of the special clinic set up by the drug company where everybody comes in and knows what's going on. So I thought you were going towards that.
Sometimes patients get very clear what the difference is between treatment and research. For example, if you have a promising AIDS drug and the patient has the option, as they have had on occasions, of either going into a controlled trial where they don't know what they'll be getting, might be getting the new drug, might not, or going into the open label part where they know what they're getting, they opt mostly for that. Mm-hmm. And that's the difference between opting for what you want and flipping a coin.
There's a regulation that we need to adhere to that requires that in research of greater than minimal risk, a medical monitor be appointed to the study, and that regulation prohibits the principal investigator from being that medical monitor, but there is no further restriction on the appointment of that medical monitor, and in common practice, the medical monitor will be an AI on the study. Would you comment on whether you feel, I hear grumblings. Okay. I don't see anything in the regulation that precludes an AI from being the medical monitor. It explicitly prohibits the PI. I would agree with that, but I was just wondering.
Is an AI an assistant investigator?
Yeah, an assistant. Right. I agree with you ethically. I don't see anything in the regulations that precludes it. Okay. I was going to ask whether or not you felt that offers any protection against conflict of interest, because I don't.
Clearly, many of your colleagues agree.
Okay.
Yes, Dr. Faden, in your opening remarks, if I remember correctly, you said that while you didn't see a distinction for the military with respect to seriously ill people, you did see distinctions in other regards, and I would be interested in hearing your comments about those.
I'd be curious to see if those of you who are in the practice of military medicine, particularly in clinical care, agree with that assessment with regard to clinical research with seriously ill patients, where it seems to me the whole dynamic is overwhelmed by the patients being seriously ill and you're being a physician and a scientist. I'm sorry I missed the discussion yesterday, but I have heard that yesterday there was discussion of the sort of issues that I was obliquely referring to. In in my role as the chair of the Advisory Committee on Human Radiation Experiments, we were charged to look hard at several experiences in military research, including contemporary experiences, and made a series of recommendations with regard to minimizing the potential for the culture of command to undermine whatever prospect there is for acceptable levels of voluntariness in the recruitment of service personnel as research subjects. And our focus there was almost exclusively not at clinical research in the sense of research at the bedside with the ill patient, but rather research that may be aimed at protecting and preventing, protecting the health of the troops and preventing harm in the case of infectious disease and biologic agents and so on, but where the potential subjects are well individuals and the context is one of a unit, for example, being recruited to participate in a research project. And there we made a series of specific recommendations, which it is my understanding that they have largely been adopted by the Defense Department in one form or another. Two of the recommendations that I'd love to know how this is filtered through to practice that were specific were related to this issue of a medical monitor. Firstly, that all officers and NCOs not be present at any session in which enlisted personnel are being recruited to participate in research. So, major recommendation. And that there be a monitor at the recruitment sessions to vouchsafe that a clear distinction is being made between military duty and this opportunity, which is perceived as is to be presented as entirely volitional and optional for the service personnel, and to vouchsafe further that there are no repercussions for any enlisted personnel who choose not to participate, that it not be part of their military record and so on, and not reported back to NCOs or officers. So it was in that direction that my comments were going.
Dr. Faden, if I may ask a question along those same lines, I'm in an office that will have to help implement some of those regulations, and I would like to ask for some interpretations. In looking at those specific guidance that officers and NCOs are not allowed to be in the room, some of the guidance that we had put forward from our office on a way of implementing that in the Army, where we have our different institutes that have groups of soldiers that remain there all the time, or we go to a field unit to immunize people, is it okay in your interpretation that we break this into two stages? One is an information briefing where officers and NCOs can be present because company commanders need to know what's going on. And second, the actual recruitment briefing where soldiers, sailors, or airmen are asked to sign a consent form that at that process, officers and NCOs are asked to leave the room. And I bring that up because company commanders are held responsible to know what information is being given to their soldiers. And company commanders get in big trouble if they don't know what's going on.
Yeah, I understand.
And an information briefing can be, terminology can change, but an information briefing can be different than the actual recruitment time, and it may actually make a more powerful statement as you go through the information briefing and they stop and say, well, we'll now ask the officers and NCOs to leave the room. And at that time, the principal investigator and the assistants with them work at seeing who wants to sign up and who wants to be recruited to be in a protocol. Could you comment on those two different interpretations?
All right, I'm speaking for myself now. Remember, the advisory committee no longer exists, so this is just me with no official whatever. As you lay it out, I think probably in principle there's no problem with what you describe. I think you could strengthen it, however, and make it even a positive guidance and an improvement over our recommendation, which is very general, by including in that that sort of briefing session that is attended by the company commander and other officers and NCOs, a few words by the company commander underscoring his understanding or her understanding that this is entirely voluntary, absolutely not part of your responsibility as a member of this unit, that we want you genuinely to understand that we are not going to know, and if it's possible for us not to know, who's agreed to participate and who's not, and if it's the circumstance in which there's no way in which we could not know, which is an issue that we did struggle with, that there are clearly and absolutely, you have my word as an officer, no repercussions that will follow from you deciding not to participate. We have no interest in this other than that you be free to make your own decision. So that if you coupled that information briefing with statements by the leadership of the unit about the principle of voluntariness as it applies to this particular opportunity, I think that would be very helpful. And probably a better interpretation of our recommendation than the simple way in which we phrased it. I also think it would be very important, however, that it not be sort of a pro forma 2 seconds. The company commander and the officers and NCOs leave, and then immediately the consent forms are in people's faces. I think you really want to distinguish the experiences to get to the spirit of the recommendation, to underscore that the people being asked to participate are now in a private environment with their peers, and maybe where they can pursue questions that they don't want to ask necessarily in front of the company commander.
Isn't one problem whether the enlisted men really believe that there's no price to be paid for not volunteering? In the clinical trial area with civilians, we routinely have this business about, by the way, feel free to turn it down, your care will not suffer, there's all these things. But I am sure, I don't have hard evidence of this, but I would be willing to bet a lot of money that there's at least occasional patients who skip right by that and feel, gee, if these nice doctors are asking me to, shouldn't I say yes?
The reason why we have 20% that don't volunteer for anything at all is they do not have the coercion of a disease.
Mm-hmm.
And you both mentioned that. The coercion of a disease is far more coercive than any company commander, first sergeant, whatever. I've seen them brought into their first briefing. Somebody will get up and present their case, and the investigator glosses over in some way the risks in order to make it more palatable, or if somebody is standing there who represents their chain of command looking like he's encouraging them to go, they'll all sit there politely and listen to the presentation, and on the way out the door you hear them say, yeah, right. And the volunteer percentage is very low. If someone gets up in front of the room and really lays it out and says, there's a real risk that you could get very sick and break out in pimples and all sorts of things, volunteerism is high. They respond like any ordinary person to the risks and benefits they're presented. And they're wearing a uniform does not affect that, I believe, when they come to these briefings.
Well, you raise a very good point. I mean, in clinical trials, for example, we know that the people who volunteer are different from the great unselected mass of patient disease, if for no other reason than the fact that there are inclusion criteria and exclusion criteria, which may end up with a homogeneous group, the results in which can't be extrapolated to the population at large. But the issue of those who could participate, how many didn't, and are they different anyway, is a question we've only addressed once, which had to do with a whole series of pain studies we did at the University of Rochester, and we looked at who, when approached, said yes and who said no. And what we found was that There weren't a lot of differences, but I remember one that came out quite impressively was that the patients who got into our studies were older, significantly older on average than the ones who didn't. And if you think about what the implications of that are, one, for example, is that the dose that you conclude is optimal for an older population, maybe terrible guess for a younger population. And we probably should look more often for whatever insight we can get as to why people didn't volunteer and how that might affect the extrapolability of our conclusions.
I want to talk about recruiting. I go around and recruit healthy volunteers for the U.S. Army Research Institute of Environmental Medicine, and I belong to the Natick Research Development and Engineering Center in Natick, Massachusetts.
Can't hear you.
And when I recruit healthy volunteers from advanced individual training courses, and I coordinate with PERSCOM to go to these specific places, and I coordinate with the NCOs and officers, and I find that they have an original distrust of me and what we're doing, the research we're doing, and if I would ask commanders and NCOs not to be in the room, that would have a negative impact on the recruiting of the volunteers. They want to be there to make sure that I'm being straightforward and honest with their soldiers. Military commanders seem to have also a general distrust, just like the public does, of military research. So to say that they're going to be there forcing their soldiers to volunteer, I find that to be not true at all. I find the opposite.
It's interesting that you say that. I think it's important to emphasize that our understanding was not that the company commander, the officers, and the NCOs are out, and the enlisted personnel are now alone with the investigators. We also argued that there ought to be a monitor who's not part of the trial or the research project, if it's not precisely correctly described as a trial that's there, that can vouchsafe two things. First, that the voluntariness is emphasized and reinforced. And secondly, that the characterization is accurate and that the service personnel should know that there's someone in the room that has no interest in their participating in either direction, but who is there to maintain the integrity of the recruitment effort. I think that it's understandable that many company commanders would have a healthy skepticism, much the same way. I mean, your experience would be very analogous to the situation, I would imagine, that principal investigators have in academic medical centers who are trying to get physicians in the community to give them access to recruit their patients. And they have often a healthy skepticism, particularly in research that doesn't offer particular benefits for their patient subjects about whether I'm going to let you in. I don't know whether I want you to let you in. So there is a gatekeeper function that I think you've properly identified, but the context I still think is such that whether it's accurate or not, it's important to address the perception that the culture of command can have an undermining effect on the voluntariness of the participation of service personnel.
And if you look at the ratio of those who are briefed and those who volunteer, I need at least 100 people to get 20 if I do a really, really good job.
I think, it's one of the awkwardness things. I mean, I think I was responding to the other comment about 20% refusal rates. I have sort of that same reaction. Your initial reaction is that it's heartening when you see significant refusal rates. Now, on the other hand, from the perspective of the ethics of the research, that's sort of awkward because sometimes, I mean, there is no way to say, well, what's the optimal refusal rate? Should it be 20%? Should it be 80%? Should it be 1%? It sort of depends, on the trial and what's available. There's no way in the abstract to make that judgment. But I agree with you that it is certainly a whole less troublesome than if you were to say to me, or Colonel Anderson were to say to me, we see only 1% refusal rate and virtually everybody signs on in a kind of herd effect. Or even there it might be that the kind of project that any reasonable person would want to be in. So, you can't conclude a whole lot from what your refusal rates are one way or the other.
I think, an important challenge to us all is going to be if we're all expected to come up with the right proportion of Hispanics, Asian American, what have you, blacks in our trials, and in fact there are serious impediments to achieving a proportional representation because, for example, of cultural attitudes. I work in Chinatown in Boston, and among members of the Chinese community, for example, it's considered shameful to have mental illness. So they don't suffer from melancholia, and so you can't recruit them because they allegedly don't have the disease. When our Human Nutrition Research Center puts ads in newspapers, including all the newspapers in town, trying to get recruits for their nutritional studies, they never get blacks responding. Now, it's been suggested, well, you ought to go to barbershops or beauty, there ought to be different venues, and I don't know whether they'll be able to solve that problem, but this isn't where they have turned away certain ethnic groups or certain racial groups. It's that there's a disinclination to participate, and we've seen the pendulum swing now from your over-including blacks to your under-including blacks. But how do we show that our inability to come up with these right proportions is not due to any bias on our part or exclusion on our part, but to cultural differences or psychological differences in willingness to volunteer? A lot of people are apprehensive about research. Not everybody thinks it's a good thing.
I'd like to attempt to answer your question, whether there is an inherent distinction between civilian organizations and the military when it comes to research in a clinical center. As a physician that has done research outside the military and inside the military, and that I work in an office which is very active in research, we looked at all the research that goes on at Walter Reed, I would tell you that I don't see an inherent difference because we are officers in the military, that indeed it is exactly the same problem that our colleagues face in academia. The worries for the patient, the compassion, the adherence to the protocol, all the dilemmas that you see in academia, we see them as well as in our clinical centers. Also, I have seen a move in the last 4 to 5 years with the best research that we do, especially when our grants from either the NIH or from other scholar foundations, in which we are required to keep lists of people that do not meet the requirements for a protocol because either they don't qualify for inclusive or exclusive criteria, or because they don't want to participate. The reason has to be cited if we want to continue getting grants. You don't have to disclose names or identifiers, but reasons for exclusion have to be identified. And we've been audited by FDA or FDA-like organizations exactly for those reasons. And people want to know that indeed physicians, at least at Walter Reed, are not quote-unquote coercing or denying entry to some patients and favoring others. So I think we face a very similar situation to the outside world. And there is a clear distinction, at least in my mind, on clinical research at the bedside and the research that some of my colleagues have talked to you on healthy people. And I think you, as member of the committee, as chairman of the committee, have looked into ombudsman and things that we talked about are part of our day-to-day operations now in research, but those apply to healthy people. We don't do that with sick patients. And I want to make that clear to the members of committees and people that are in the audience that there are separate channels on how to still do very ethical research.
Yeah, thank you. That's very helpful.
A couple of discussions ago talked about from the patient's point of view, I want to expand it. It's not just a problem of conflict in the doctor and researcher in the same person. It is when the patient is presented with his or her doctor wanting to be his or her researcher as well. The choice is not just the loss or the manipulating hope. It is the coercion of, if I refuse to have the person be my researcher, do I then lose that doctor relationship with my provider? So that there's a conflict in that way as well. I was wondering if you'd like to comment on that.
Yeah, I mean, that is probably the most acute context in which the patient is put in a, I don't know exactly what modifier to use, let's just say a difficult situation, the context in which the person was previously that patient's treating physician and now wants to enroll her patient in her own trial. And this is, as Dr. Lasagna mentioned, the context, I think, especially, and we heard it in interviews with patients who say, I don't want them to be mad at me. It's the, well, nothing will happen and we won't change your standard of care and nothing will change at this institution if you say no, but they won't like me as much. And therefore, they won't take care of me as well and they won't pay as much attention to me as they will to other patients. And I can't risk that because I'm very seriously ill and these people are my lifeline. So if they want me to go on this trial, the last thing I'm going to do is antagonize them. And that's an understandable human response and one that we have to be very respectful of. I'm not sure what the answer is. I'm not prepared to say that a person may never recruit his or her own patients into a trial. It troubles me deeply, though, that we often fail to recognize, to use a term I ended with, how morally perilous that kind of enterprise, in fact, is. And I don't have a clear answer except to say that we have to be remembering how we're treading on the trust and dependence of the very ill when we do that.
I'd like to return to the question of the unwelcome offer. In particular, the issue was raised about what do you do when the research protocol, in order to enter into the treatment arm, requires an additional procedure or submission of tissue for the purposes of research that may not be directly related to the study at hand. And in the Air Force, we require two separate consents. We consider that inappropriate. A person may choose to participate in the treatment arm of the study or not. But that the access to treatment through protocol should not be dependent upon submission to another procedure or a blanket forever approval to my tissue surgery. And so when we catch that happening and NCI protocols are in place else, we require that there be two separate consents, one for the treatment arm and one for the other.
Yeah, I think that's very admirable, and I have seen that at our institution as well. The problem becomes often in interpretation about what interventions are either unrelated enough to the clinical management of the patient or noxious or burdensome enough that they need to be separated off and made an independent but related part of the trial. You also see this when social science research is added on to clinical medical research and the importance of recognizing that one can agree to participate in one part and not in the other part. I want to be in the interview study, but I don't want to be in the drug arm of the trial, or vice versa. I want to be randomized into the drug, but I don't want anybody to follow me to check on my quality of life for the next 20 years. And these are often all bound together in a way that I'm not sure we're sure about how the circumstances under which it's permissible to bundle these elements of the research agenda and when it is required morally that we separate and hold out as distinct the elements of the research agenda.
I think the issue comes down to what is the objective of the study and is it possible to separate the two?
Right.
And if it's not possible to separate them in a rational way, then the person's option is not to participate in the study. One doesn't, bisect something which can't live in two halves.
Correct. That's a very good way of setting it up, very good way of framing it.
Since I brought that up, I just want to make a comment that we also looked at it that way. But what I'm talking about is the conflict that if you're a member of a cooperative study and the requirements of the group,
Right.
right, not the institution. I mean, the Air Force can say, okay, you need 2 consent forms, but what the group is saying, I don't care if you have 2 consent forms. If you're not in A, you don't get it. And so I think that's a different issue. We try to, the reason I'm bringing it up here is that part of the rationale
Yeah.
that we present those numbers. And so I bring that only up because it's something that is subtly built into some of the longer protocols. And you look at it and say, well, this is just a biopsy, but I think the ethical principle is greater. And so I concur with what the Air Force is doing. We've tried to do that, but if the group says 1 for 1, you've got to buy 2, that's a different issue because then you can't offer the therapy at all because you can't offer it outside of the collaborative study. No other way to get it.
I have one question from the floor, and I think with that we're going to close the session. When it comes to a child with cancer, do any of you would suggest a party that represents the child other than the provider or the family? Would you suggest that?
In pediatric cancer research. Sometimes would be the answer. And that's, I mean, in my experience with colleagues in pediatrics, whether it's cancer or it's HIV, there's almost an intuition, which is very difficult for an I or B to deal with, but is very appropriate, I think, to the clinical situation, that guides the pediatric care team as to the extent to which the parents are functioning well as advocates for their children, and a learned wisdom about when it's necessary to intervene on behalf of the child through some other mechanism. The problem, of course, that I think our audience member is suggesting is that it goes back to the core of our whole session, when the pediatric care provider is now also the investigator, the allegiance or the loyalty of the pediatrician and the pediatric nurse and the other specialists involved is somehow suspect with regard to the interests of the child. So it gets a little bit more complicated. But here again, I am uncomfortable about taking the position that in all cases of pediatric research with seriously ill children, there needs to be an independent advocate for every child that is separate from both the pediatric care team and the parents. I think, however, there are instances in which that kind of an advocate is appropriate, but it's very difficult to come up with sort of abstract criteria for when that is the case. It has something to do with how serious the medical condition is. It has something to do with the relationship of the pediatric care team to the research itself. But very often it is an individualized situation that needs to look at the particular child.
A concern that has been repeatedly voiced by United Kingdom physicians has been whether you should involve a child in giving consent when you're dealing with a dreadful disease where laying it out the way you do in most consent forms, rather bleakly, the truth is so painful that it's considered possibly damaging to the child. Now, other people have said, well, what makes you think that the average child isn't aware of the fact that they've got a bad disease, that you can't talk to them about it? But it is, I think it's a legitimate question to ask whether there are situations with any kind of patient where some sort of surrogate consent form should at least be considered lest the patient suffer grievous psychological harm.
Dr. Fadin, Dr. Lasagna, thank you very much.
For our final session today, we're lucky to have with us Dr. James Childress. Dr. Childress is the Edwin B. Kyle Professor of Religious Studies and Professor of Medical Education at the University of Virginia. He co-directs the University of Virginia Health Policy Center there, and he's here today actually in a different capacity, and that as being a member of the NBAC, the National Bioethics Advisory Committee, and in that he chairs the subcommittee on human subjects issues. And so he's here to talk to us a bit about what is happening at NBAC. Dr. Childress.
several months ago, I agreed to make this presentation and participate in this very important symposium. And at the time, I was fairly confident that the National Bioethics Advisory Commission, or NBAC as I will refer to it, would be fairly far along in its deliberations about human subjects protection, perhaps even to the point of proposing recommendations. But then along came Dolly, and virtually all we have done since late February is to think about the implications of the Dolly experiment for human cloning, somatic cell nuclear transfer to engender or create children, in order to produce a report for President Clinton, which we delivered to him a week ago yesterday. And I missed the session this morning, except for the last few minutes of the very interesting discussion. I was here much of yesterday, and I wanted to hear the whole program, but unfortunately, Senator Frist has a subcommittee looking into cloning, so I was down talking about those issues. So all I can do is really report on some of the things we have thought about, or some of the things I think we will think about, and give you an indication of our overall approach. But unfortunately, I can't tell you we have reached a consensus on certain matters of importance in the area of protecting human subjects. I will use the metaphor of gaps to refer to much of the work of the Commission. It's not only gaps in our work, but rather an indication of the direction we're taking. And before I do that, I want to say a word about NBAC's formation and its directions, and then talk specifically about what's being done and is being proposed for us to do in the area of human subjects protection. Why NBAC? Well, in the wake of several disclosures of a number of unethical experiments in the 1960s and early 70s, the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research was set up. And that particular commission built on proposals and practices that already emerged on the level of procedure to firm up the Institutional Review Board as a central mechanism for protection of human subjects. And it also proposed guidelines, many of them later formalized as regulations, of a substantive nature to protect human subjects. And the common rule was developed in '91, and at one point in a discussion with Charles McCarthy, former head of the Office of Protection from Research Risk, who was here yesterday, I recall him saying that as he attended and participated in meetings around the country, most of the concerns that were raised had to do with protecting animals, not humans. Then why the National Bioethics Advisory Commission? Well, in part because of the work of the Advisory Committee on Human Radiation Experiment, chaired by Ruth Faden, from whom you just heard. Because that report not only looked at what had been done, but also rethought the legacy of those experiments for the future. And in part in response to the report of the Advisory Committee, President Clinton set up the National Bioethics Advisory Commission, established by presidential executive order in late 1995, members appointed in '96, and the first meeting was held in October of '96. The 18 members of the commission, according to the charter, should be drawn from knowledgeable non-government experts and community representatives with special qualifications and competence to deal effectively with bioethical issues. At least one member should come from each of 5 categories: philosophy, theology, social behavioral science, law, medicine, allied health professions, and biological research. The charter requires NBAC to provide advice and make recommendations to the National Science and Technology Council in the White House, to other appropriate entities and the public on bioethical issues arising from research on human biology and behavior, including the clinical applications of that research. Now, according to our charge, NBAC must give immediate priority to 2 major areas. One area is the protection of the rights and welfare of human research subjects, and the second has to do with issues in the management and use of genetic information, including but not limited to gene patenting. The chair of NBAC, Princeton University President Harold Shapiro, and a very effective chair indeed, divided NBAC into two major subcommittees to deal with these two tasks. And as Ruth mentioned, I'm chairing the Human Subject Subcommittee, and Tom Murray of Case Western Reserve University is chairing the Genetics Subcommittee. Now, there are important differences in approaches between these two subcommittees. In the area of protecting research subjects, there's already a lot of very important substantive and procedural protections in place. Hence, the task of the subcommittee, and thus NBAC as a whole in this area, is to examine what already appears in law and regulations and guidelines and practices to determine whether there are major gaps that need to be filled. And as I mentioned, I'll use this metaphor of gaps to suggest what's involved in much of our work. By contrast, the Genetics Subcommittee has to work largely from scratch in a number of areas because of the general absence, or at least patchwork, of laws, regulations, and guidelines. So the main task for the Human Subject Subcommittee is to plug gaps, perhaps by modifying what already exists or adding to it. In contrast, the Genetics Subcommittee has to create. Now, the Genetics Subcommittee decided for this first year to concentrate on tissue samples, a topic that's already been raised, mainly stored tissue samples. And this might sound like a very narrow topic, but as a matter of fact, it raises a number of significant issues about the ownership of such samples, the way DNA research involves parties in addition to the one from whom the tissue came, concerns about discrimination based on genetic information, and the like. And it obviously connects with the research area too. And later in June, there will be an interagency human subjects conference that some of you may be attending on genetics research and human subjects, the changing landscape. Now, in addition to the background direction I've just indicated, since we were set up, a couple of things have happened. One is the further response on the part of the Clinton administration to the report of the Advisory Committee on Human Radiation Experiments, a report entitled Building Public Trust, and this was a further response again of the administration to that report. And that response indicates some other areas in which NBAC should be active, and I'll mention a couple of those later. And then there was the apology to the survivors and families of survivors of the Tuskegee syphilis experiments. And as part of that, there was an announcement of an extension of NBAC for most of this period since October. We've been working under the uncertainty about whether we would continue to exist and whether funding would be available and so forth, but that has been now taken care of, at least for a few years, and that's important as we try to deal with an area as complex as human subjects protection. Now, what I want to do is, using the metaphor of gaps, think about where in the substantive standards and procedural protections there are gaps that we might think about trying to fill. One mandated task we have is a single task that's been singled out as what we need to do within the first year is discuss federal agency protection of human research subjects, especially compliance with the common rule. Now, we have to assess the adherence of federal agencies to the common rule and plans to improve their adherence. Are there gaps in adherence on the level of structure, that is, things are not in place? Are there gaps in adherence in terms of practice, particularly the procedures and processes that are followed? Now, this is a task that at first to some of us perhaps appeared to be quite routine, but it turns out to be a quite significant one as well. And we're very fortunate to have Bill Freeman with us half or three-quarters time, or he's working a lot in several different places, but we're really fortunate to have him chairing a small staff in working up materials for NBAC in this particular area. Now, The common rule suggests that, and you're familiar with all of this, in areas of protection of human subjects, that risk to subjects must be minimized, must be reasonable in relation to benefits, selection of subjects must be equitable, informed consent, monitoring if appropriate, privacy and confidentiality, and so forth. Now, we're interested in determining the extent to which the federal agencies that list themselves as complying with the common rule, have signed on to the common rule, are in fact structured so that they are able to protect research subjects under the rule in terms of the processes and procedures followed, as well as the actual structure. A lot's involved here. How does the agency define research? How does it view exempt research? How does it handle expedited review? How does the agency handle issues of informed consent, and so forth? So many different questions arise here, and one of the questions we will raise, and more generally, is whether there are certain gaps in structure or process that need to be filled. A second kind of question that comes up is whether the common rule should be extended to other federal agencies and to privately funded research. Is this a gap in our current protection of human subjects? So you can think about this extension in several ways: to research not now covered because it's not viewed as research, a point I've already made, to the federal agencies that have not signed on to the common rule, and especially to privately funded research outside institutions that basically extend the common rule to all subjects involved in research. Now, some say the protections that exist are adequate because, after all, take an example, drug companies must submit applications to the FDA, and thus they have to satisfy human subjects protection in order to submit their applications. But there's a lot of research going on that may not be subject to that kind of protection. We don't know. This is a huge gap in our knowledge. Gary Ellis, head of the Office of Protection and Research Risk, has argued that the most vulnerable population is the group of research subjects not brought under the common rule. And fellow Commissioner Altachero of the University of Wisconsin has argued over several months that NBAC ought to affirm an ideal or principle of universal protection through IRB-like mechanisms and informed consent at a bare minimum. Now, there's been some debate among commissioners about how to proceed in this area. Should we affirm an ideal or principle without clarity about how it would be implemented and what kinds of costs might be involved? If by doing so, this would serve as a point of reference for our other discussions as the ideal or principle. Others have argued that it'd be preferable to consider the need for this protection, this extension, how it might be implemented, and the kinds of cost it might engender. And that was the kind of debate that was beginning to go on prior to Dolly. And then we affirmed in our report on human cloning this ideal, at least in an oblique way. So the Commission is on record as viewing this as an ideal or principle. And then, of course, we have the Glenn Bill and other efforts to plug this gap. But another question is whether there might be gaps in the common rule itself. Questions arise about vulnerable populations, protection of children. There may be gaps, for example, in the way minimal risk is understood and interpreted. So you could, for vulnerable populations already identified, raise questions. But one area that the Human Subject Subcommittee is very strongly committed to trying to cover is the protection of cognitively impaired or decisionally impaired research subjects. The National Commission back in the 1970s proposed guidelines for those institutionalized as mentally infirm, and these were never adopted for a variety of reasons. And then came deinstitutionalization, hence a much broader population than those institutionalized as mentally infirm. But many argue that the failure to adopt guidelines to protect this vulnerable population means that some research that's very important is not being done, and that some research is being done inappropriately, and that we need the guidelines both to ensure that the research will be done that needs to be done and that it will be conducted appropriately. And again, this is an area that we have begun already to examine, but we're not yet at a point where I can say it looks as though the subcommittee and NBAC as a whole will do the following things. Another possible gap is in the implementation of the Common Rule. Questions have arisen about the important structure that we use, the Institutional Review Board. Over the last 20 years, since the work of the National Commission, the responsibilities of IRBs have increased tremendously, particularly as research has increased and regulations have increased. And so a number of articles have appeared indicating that IRBs are overworked, not adequately supported by institutions, and so forth, as well as, in some cases, facing themselves institutional conflicts of interest. Now, this is an important area. It's recognized to be very important, and in the report on building public trust, President Clinton said that NBAC has undertaken to review the current IRB system and intends to finish that project within a year. Now, that's an optimistic political statement. Without knowing whether it would even exist past October of '97, we have not undertaken to review the whole IRB system. There are some studies underway. Charles McKay's important study, the Office of the Inspector General for the Department of Health and Human Services, also has a study underway of in-hospital, hospital-based IRBs. So those two together will give us some information. But now that we know will exist past October of '97, as we get information from these two studies, we'll need to look and see whether there is something else that needs to be done, perhaps a more comprehensive one, that will really enable us to get at the question, how well are IRBs doing? Now, questions arise of a broader sort about IRBs. If we go back and look at the original rationale for IRBs, does that rationale still hold? Some have proposed we really need to move to alternatives to local IRBs, regional boards or specialty boards or super boards. Well, in some cases, the need is clear. In conflict cases, ad hoc groups are set up to deal with these issues. A very interesting one last fall focused on the controversy about research protocol involving clean needle exchange programs. Or maybe in other types of research where there are serious public concerns or the need for special expertise, again, you might want to go to some sort of super board. We have some examples. One example in the area of gene therapy has been the review by the Recombinant DNA Advisory Committee of such research, since not every institution has expertise in this area for review purposes. Others have argued that an area like xenograft transplantation, which raises public health concerns, we need to have a broader kind of review of the ethical and social issues, not simply the scientific ones. And then there's the matter of relating IRBs to data and safety monitoring boards, which play a very important role in our research programs, particularly clinical trials, and yet there's not really a good feedback mechanism or close connection between IRBs and data and safety monitoring boards. How should that relationship be handled? Let me move to 2 or 3 other possible gaps and then close and hope allow a few minutes for questions. Another kind of gap is created by exclusion from research rather than by a lack of protection. So far I've concentrated on lack of protection. But there's been at least a direction of a shift in the paradigms of research and paradigms of ethical issues in research. The earlier paradigm, the one that was dominant when the National Commission operated in the mid-1970s, focused on the risk and burdens of research and the need to protect potential and actual research subjects from harm, abuse, exploitation. The model was non-therapeutic research, and the guidelines following Nuremberg placed primary emphasis on voluntary informed consent, as well as the other criteria that I mentioned. According to one commentator, Carol Levine, our basic approach in the U.S. was born in scandal and reared in protectionism. The dominant model, again, in protectionist policies is that of non-therapeutic research, research that doesn't promise any therapeutic benefit to the subject. Well, a significant paradigm shift has occurred from protection to access, as well as from non-therapeutic to therapeutic research, from risk and burdens of research to possible benefits. Why this shift? Well, especially, but not only because of the epidemic of HIV infection and AIDS, with AIDS activists being very vocal in this area in arguing not only for FDA expansion of access to new treatments, but also expanding community participation in design, evaluation, and the like. This shift, and it's reflected in other areas too, is again a shift from protect me from research to include me in research. And yet, as important as this shift is, I think we have to be very careful not to give up what was important in protectionist policies now in order to implement inclusionist policies. We need to retain what was important at the first and now make sure we cover the gaps in the second. Another gap has to do with compensation for research-related injuries. As Bob Levine mentioned, we're the only developed country that does not cover research-related injuries, but other developed countries do so in part under the provisions of health care to the community or society at large. Given that gap in our health care coverage, the absence of compensation, including medical care for research-related injuries, serves as a huge gap. The first thing I ever did in relation to federal government policy in biomedical ethics was to take part in a discussion about 20 years ago at NIH on compensation for research-related injuries. This topic has been discussed a long time. Injuries are not that common, though they do occur. One of my favorite examples was of one research subject who was bitten by another research subject. But even deaths occur, as you well know. What kinds of arguments can be offered for compensation? Some of them have to do with justice, trying to compensate those who have assumed a position of risk on behalf of society and who, through no fault of their own, have now been injured in the process. The document Building Public Trust indicated that the administration would be open to considering any recommendations on compensation of research subjects from NBAC or legislation from Congress that seek to address this issue. But that was preceded by a paragraph that said, in the absence of a finding that significant number of modern research subjects are unfairly denied compensation, the administration is not prepared to propose a system, though again it would be willing to listen to proposals for a system. Now, the last big gap I would mention is one that has to do with a possible gap in the Belmont principles themselves, or at least in the interpretation of those principles. And perhaps I can state this best by saying that some have argued we need to move away from the individualistic model that was dominant in the formulation and interpretation of Belmont to a more communitarian model. Parenthetically, in using this metaphor of gaps, that may seem to suggest that our work is really bureaucratic in nature, but a lot of what is involved is actually conceptual and normative, trying to determine, for instance, how the Belmont principles are being understood and how they might be modified, at least in interpretation, if not formulation. Our task is to look at broad overarching principles to govern the ethical conduct of research, not to look at particular protocols. Well, you know the principles well, and the way in which they're specified then in various guidelines, respect for persons, beneficence, and justice. And you know how they've been interpreted. Well, our first NBAC meeting, one commissioner said what we really need to do is add a fourth principle, community. Well, did that member mean really add a principle along with the other three? That's one possibility. Or to interpret or reinterpret the other principles in relation to community. Community has been involved in the way we think about beneficence. But we could think about respect for persons, for instance, not simply as focusing on isolated individuals, but individuals as parts of communities. That would be one way in which a communitarian lens might lead us to see some different things. Or in the area of justice, you've already heard a discussion of participation of communities in research protocols, design, evaluation, as well as actual participation. Could we also think in different ways about justice, for instance, in the provision of compensation to injured research subjects as expressing community solidarity with those who have taken on the risk of participating in research on behalf of the community? So there are several different ways in which we might try to think, I'm just giving you some examples, about the Belmont principles in a less individualistic and more communitarian way. There are gaps in trust in the United States. The Tuskegee syphilis experiment apology was in part designed to look at that. NBAC is also expected to try to do something in this area of stimulating public trust so that research can go forward and research subjects can be protected. But a big gap we face is a gap in knowledge. We don't know a lot about IRBs. We don't know a lot about the informed consent process in contrast to informed consent forms. So even as we try to plug some of these other gaps in knowledge will continue to haunt us. Let me stop there and at least have a couple of minutes for discussion, if that's all right, Ruth. Okay? Thank you. Yes.
You mentioned that you didn't know of any gaps in groups that should be included in protection of IRBs that aren't. And I know of a huge gap that occurs partially institutionalized at all hospitals, which is in the ACHO-driven requirement for continuous quality improvement. There are numerous departments that do projects that should come under an IRB. They look exactly like an IRB project. The only difference in their conduct of them is that they don't go to an IRB because they call them quality assurance projects. Yeah. And then often they come to us as IRBs and say, this was interesting data, can we publish it?
Right, right. No, I very much appreciate that point. And if in speaking too rapidly, I gave the impression that we weren't aware of any gaps, I misspoke. And one gap I certainly emphasized was cognitively impaired or decisionally impaired subjects. But in addition, precisely the point you have raised has been raised, and that's something that needs further attention. I quite agree with you. Thank you for raising it. Yes?
Dr. Childress, can you hear me?
Yes.
The question I have is a little on the light side at first, but it gets heavier as I go along, and it goes like this. You mentioned the great dirty word in the military, politics. Military people try to avoid politics. Yet, obviously, what you're doing has some political linkage, as you suggested. There are, however, politics that go on in all institutions, not only hospitals, but in Pentagons. And what we have seen over the years is a tendency to exempt certain types of research from any kind of informed consent. You probably are fully aware of the passive consent movement and that sort of thing. And sometimes it's not private, sometimes it's a congressional grant to some small college or institution or friend who then carries it out as if it were their own resources and doesn't feel they have to obey any of these grand designs or statutes or whatever. Do you consider that to be within the realm of your gaps, or where do you fit politics, sir?
Thank you. And I only mentioned it briefly in passing in relation to the common rule and the interpretation of research under that heading. One of the things we're interested in looking at is how federal agencies, and again, you could extend it well beyond federal agencies, but how federal agencies understand what they're doing in terms of whether this counts as research or not, but also whether it counts as exempt research or not. And obviously, categories like that require interpretation, and part of the process that goes on is trying to determine exactly how they're being interpreted, are those interpretations problematic? That is, do certain kinds of research efforts to generate generalizable knowledge get through when they really should be examined carefully by an IRB? So yes, we are looking into that, and I think that may well be one very important gap that needs to be thought about further. Not necessarily that the guidelines and regulations have to be changed, but our tradition of interpretation may need to be changed.
But you've mentioned the agency. How about the politicians?
Oh, I resist making certain kinds of comments, but yes, it would be important to have public and political and professional education.
Thank you.
What consideration might be given?
Hi, Ron.
Hello. What consideration might be given to the desire on some parts for greater oversight of conduct of research following its initial approval by IRB versus the overload of IRBs already?
This is something that a number of people are concerned about. I think it's a very important concern, and we have not, that one is one that's just been mentioned, the process of monitoring. That is, monitoring what actually goes on in terms of the consent itself, but also in terms of the conduct of the trial, because as your comment suggests, IRBs operate with a lot of trust in relation to investigators. That is, they approve the protocol, including the consent form, and then, for the most part, investigators are trusted to carry out what has been set up. But we don't know how well that's been done. I agree that this is an important area for further examination. That's about all I can say. Just agree. Okay. Okay, I guess we'll make this the last one.
I have one question.
Okay, the last question.
Thank you. Earlier, I submitted a card question concerning the vacancy provisions in patent laws with regard to genetic material collection and intellectual property rights. My question is, what is the Advisory Commission's opinion as to whether it is unethical not to inform research participants that their genetic material may be patented or exploited commercially?
I can't speak for the Commission on this, and I think there are others in the audience who probably could address it better than I. If I speak personally, I would view that as an important information to disclose. Now, the Genetics Subcommittee and NBAC as a whole will be looking further into this, because I think this is an area of great importance, but also a controversial one as to how to work out the best way to handle it. So I quite agree with your concern. Can assure you that NBAC is going to be looking into it as part of the report it will make in October, but can't at this point say exactly what the recommendation will be. Thank you for the question, and thank you for your attention.
I'd like to thank Dr. Childress and all of our speakers. I think they've been just wonderful. And I'd like to thank the organizing committee, who will be meeting in about 10 minutes down the hall to try to draw some conclusions. And then I'd like to thank the staff who've worked so hard in all of this. And finally, you as an audience, thank you.